Assalamu alaikum. This presentation is on olfactory dysfunction and smell rehabilitation with a special reference to post-COVID smell abnormalities. In the adult general population, nearly 20% of adults have a pre-existing olfactory dysfunction of some degree. This would increase to almost 80% in those who are over the age of 75. This is reflected in the incidence of olfactory dysfunction in COVID-negative patients in the last 2 years. This accounted to about 20%, resembling the figure for adult general population olfactory dysfunction. More than 90% of the patients with COVID-19 had some degree of olfactory dysfunction. 45% of COVID patients had only either anosmia or agwesia as their symptom. There are three main causes for olfactory dysfunction that accounts to almost half of all the patients. Each of these three causes account to between 10 and 20% of the cases. They are viral upper respiratory tract infection, head trauma, and chronic rhinosinusitis. The olfactory epithelium in the superior part of the nose stretches to about 2 centimeters square in surface area. And contrary to many textbooks, it cannot be differentiated easily from the surrounding respiratory epithelium by the naked eye. Only 10 to 15% of the incoming air would reach the olfactory neuroepithelium, and conductive olfactory dysfunction can be caused by things like polypi in the upper part of the nose of the superior turbinate that blocks the ingress of air to the neuroepithelium, or by excessive removal of the inferior turbinates that can shunt the air directly into the nasopharynx, bypassing the superior part of the nose. The nasal respiratory epithelium and the olfactory neuroepithelium both have a high level expression of the ACE2 protein. This is the gateway for the COVID-19 virus to infect cells. The various types of olfactory receptors are color-coded here. The same type of receptors would have connection with an olfactory sensory neuron, and axons of similar types would converge to form a phyla that passes through foramens of the cribriform plate to converge into a glomerulus cell of the same type, and through the glomerulus cells the signals will pass to mitral cells and then to the brain. There are around 6 million receptor cells in the olfactory neuroepithelium. Axons of similar type of cells would converge to form a fasciculus that would pass through foramens of the cribriform plate to synapse with the second-order neuron in the olfactory bulb. The synapses are called glomerular layer, and from there they would pass into the second neuron order, the mitral cells, and through the mitral cells the signal will be transferred to the brain. The olfactory system uses glutamate to excite the olfactory bulb neuron, while dopamine is used to regulate and modulate the olfactory input. The olfactory epithelium has a unique power to regenerate. Throughout life, various injuries from viral or bacterial inflammation or from trauma would lead to metaplasia of the respiratory epithelium. But the basal cells, which is a form of a neural stem cell, will continuously proliferate and divide and differentiate into olfactory neural cells. Land mammals has 4 different neural systems in their nose. The main olfactory system, that's cranial nerve number 1. The accessory olfactory system, the vomeronasal system, which is rudimentary in humans. The trigeminal somatosensory system, which carries sensation of pain, temperature, irritation, and the nervus terminalis, or the terminal nerve. This is cranial nerve number 0, which carries signals from pheromones. Again, rudimentary in humans. When the neuroepithelium is injured through, for example, a viral inflammation, Its regenerative ability is increased markedly with formation of new olfactory receptor cells and the formation of new neural connections, but some of them may be faulty. In addition, there is also regenerative activities at the olfactory bulb level with migration of new neural cells and formation of new circuits in the olfactory bulb and the brain. The neuroepithelium regenerates rapidly, but the pace of the regeneration is slowed down in the elderly. In animal models like rats and mice, when the neuroepithelium is completely injured, it takes about 1 month for it to regenerate completely. There are three types of olfactory dysfunction. Conductive dysfunction, when the airborne odorants cannot reach the superior part of the nose due to tissue edema or polyps, for example. Sensory neural dysfunction, when the olfactory neuroepithelium is degenerated due to injury from bacterial or viral inflammation or direct injury or drug-induced impairment. Central dysfunction, when there is neurodegenerative conditions in the CNS or head injury. The dysfunction can be complete in anosmia or it can be partial in hyposmia. It may be associated with a distortion of the perceived odor in dysosmia. This can be either due to actual odorants in parosmia or can be spontaneous and imaginary in phantosmia. There is also another type of olfactory dysfunction in heterosomia when all odors smell the same. COVID-19 virus causes olfactory dysfunction by disruption of various levels. In the nose itself, there is usually mild signs of inflammation. There are no signs of olfactory cleft obstruction or polyp formation or sinusitis, but there may be some mild infiltration of lymphocytes and plasma cells and rare neutrophils. It's the neuroepithelium that carries the brunt with degeneration of the neuroepithelium in the superior part of the nose. There are also some disruption at the CNS level with swelling of the olfactory bulbs and signs of reduced metabolism in the regions of the brain that process and integrate smell functions. Objective olfactory tests are required because the patient's self-report of olfactory loss is unreliable. These tests function in one of these three areas, either identification of a specific odor, assessment of the threshold, or discrimination of the presence or absence of a certain odor. The most widely used test is the University of Pennsylvania Smell Identification Test. It's an identification type of test in which the patient will be asked to identify the odors of 40 different microcapsules. If the patient scores anything above 34, this is normal smell. Anything between 20 and 34 is hyposmia. Anything below 20 up to 7 is anosmia. Less than 7 may reflect avoidance from the patient's part, since the chance performance is about 10 out of 40 anyway. The other common test is the sniff and sticks, more commonly used in Europe and the UK. This is if the University of Pennsylvania is an identification test. This sniff and sticks test it actually works by an identification, assessment of the threshold, and discrimination of the presence or absence of odors. If the patient scores anything above 30, this is normal sense of smell. From 15 to 30, it's hyposmia, and less than 15, it is anosmia. There is a Japanese objective olfactory test called the T&T, which identifies the detection threshold and the recognition threshold and produces an olfactometer. If the patient had an isolated loss of smell for more than 3 months and his nasal endoscopy showed no abnormalities, then an MRI scan would be indicated. except if the patient had a positive history of COVID infection. But if there is no history of COVID infection, or if the COVID status is not known and the nasal endoscopy is normal, an MRI scan would be recommended. It's interesting to note that the rate of positive findings in an MRI scan in isolated loss of smell is very, very low. In fact, no greater than the positive findings in MRI scans in general population having MRI scans, for example, for other CNS or eye problems. But if the patient has isolated loss of smell and the nasal endoscopy showed some abnormalities, then CT scan may be preferred to MRI scans. The CT scans can be carried out without contrast unless a neoplasm is suspected. CT scans are not indicated if the patient had a recent history of upper respiratory tract viral inflammation, or if his nasal endoscopy is normal, or if he has no associated neurological symptoms or signs. Anosmia or severe hyposmia are very common in COVID-19 patients, but within a week, about 80% of them would report some improvement in their sense of smell, and 11.5% of them would have their symptoms completely resolved. There would remain about 20% of the patients who would have their symptoms either unchanged or getting worse within a week of follow-up. After 4 weeks, there will still be about 17.3% who had persistent loss of smell. The overall improvement rate of the patients would be around 80% after 4 weeks. The first consideration in the management of persistent olfactory dysfunction in COVID patients is safety. Patients should be advised to maintain smoke and natural gas detectors. They should also be advised to check their food expiration dates, and because of the anosmia, some patients may not be able to have their regular food intake, and they should be counseled about that. The mainstay of the management of persistent olfactory dysfunction, however, is the olfactory training. And the number one step is deliberate sniffing of 4 different odors, for example, rose, lemon, clove, and eucalyptus, each for 20 seconds, twice a day for at least 3 months, plus some adjuvant medications. Intranasal steroids may be indicated if the patient had persistent loss of sense of smell for more than 2 weeks and associated nasal symptoms in the form of sprays, drops, or rinses. On the other hand, oral steroids may be indicated as an optional treatment even if the patient has no other nasal symptom apart from the persistent loss of smell for 2 weeks. It's not recommended, however, to prescribe oral steroids if the patient has persistent COVID symptoms. These 3 supplements were tried in the management of olfactory dysfunction in COVID-19 patients. The supporting evidence is limited to such an extent that no recommendation can be made on either vitamin A drops are useful or not. There is a not recommended version for the alpha-lipoic acid. There is no clear evidence that it helps at all. And for the omega-3 supplement, the recommendation is optional. Another supplement is the zinc sulfate, but again, there is no clear evidence to support its use in the olfactory dysfunction patients after COVID-19. The rationale behind trying it came from a trial that showed that 50% of the patient would have a lower zinc concentration. The other half, the other 50% who have normal range, would exhibit a greater improvement of their olfactory function. And further to that, the 50% who have low concentration, when they were treated with zinc supplement, they exhibited a tendency for olfactory function to improve. Thiophelin is a non-specific phosphodiesterase inhibitor that increases the intracellular concentration of CAMP in neurons. The rationale behind suggesting thiophelin in the management of olfactory dysfunction came from a previous trial in which another phosphodiesterase inhibitor was used in the management of patients who had sudden sensorineural hearing loss. Some of these patients had reported improvement in their olfactory threshold. The thiophelin was tried in an open-label trial in patients who had post-viral olfactory dysfunction, and about 50% of them had reported subjective improvement in olfaction. The evidence supporting the use of macrolides in anosmia patients is insufficient. There were some reports that examined the use of erythromycin, clarithromycin, and roxithromycin for the treatment of the olfactory dysfunction caused by chronic rhinosinusitis. A randomized controlled trial was tried with roxithromycin in chronic rhinosinusitis patients and did not show any significant improvement. But the mainstay in the management of olfactory dysfunction in COVID-19 patients is the olfactory training. This is in fact olfactory learning process rather than just mere exposure to odorants. The exposure to the odorants would stimulate the regeneration of the olfactory neuroepithelium and also the regeneration of neurons in the olfactory bulb and the formation of circuits in the brain. The exposure to odorants would also, and perhaps more importantly, help in the integration of the new brain connections and the new neural circuits in there, so that would lead to a better smell identification and discrimination between odors. Smell rehabilitation would require at least 4 different scents, particularly scents that the patient can remember. The most widely used 4 scents would be a floral odor like a rose, a fruity odor like a lemon, a spicy odor like a clove, and a resinous odor like eucalyptus. The patient would sniff from each pot for about 10 to 20 seconds, once or twice a day for at least 3 months. It's important to try and memorize the scent of the pot during the act of sniffing to help in the reformation of the neural circuits in the brain. Why these 4 scents are the most often used in olfactory retraining? They cover 4 of the major groups of aromas, including flowery, fruity, aromatic, and resinous. They have been tried and showed positive effects in improvement of the olfactory sense in patients who have hyposmia and anosmia. Some scans had showed increase in the volume of the limbic system and the thalamus after the use of these odorants. There were other reports that the use of more odors types in addition to these 4 did not improve the results any further. And there was a standardized trial that combined the use of these 4 scents with oral steroids and showed significant improvement in the sense of smell after COVID-19 olfactory dysfunction. But the use of household aromas and odors can also be very useful. Things like vanilla, coffee, a piece of lemon, some herbs like mint, thyme, or rosemary, toothpaste, washing up liquid or laundry soap, mustard, ketchup or brown sauce, and burnt toast can all be tried. So does it work? A meta-analysis of 13 randomized controlled trials of olfactory training has showed a small to moderate benefit for patients who have olfactory dysfunction after COVID-19. Olfactory dysfunction patients after COVID-19 will often report disgusting smells, particularly when they are having their meals. For those parosmia patients, the advice would be to have cool or room temperature food because they are less smelly, and to just continue on having their meal because it was noticed that after the third mouthful, the sense of parosmia would be reduced. They would also be advised on the common and known triggers like coffee, like roasted or fried meat, like deep fried food, eggs, garlic, onion, uh, toothpaste, mint, and chocolate. Toasted bread is also a known trigger. And to try bland food like rice, boiled potato, and sometimes yogurt, plain yogurt, dried food, nuts, apples, and grapes. Adding cinnamon to their sweets or the toothpaste flavored cinnamon would also be less irritating. By this, we come to the end on this presentation on olfactory dysfunction and rehabilitation with special reference to post-COVID-19 olfactory dysfunction. Assalamu alaikum.